He loves what he does. We're excited that I'm able to work alongside him each and every day. Without further ado.
Well, good afternoon. As Bryana said, my name is Willis. I'm the Director of Clinical Services here at Cross Creek. I'm going to share my screen so you all can obviously follow along.
And we do have some distance between your microphone, so we need to talk a little bit more projection to the microphone there.
1 second. All right. Can y'all see this?
Yes. Thank you.
Perfect.
Maybe move a little closer to you guys. All right, if you have any trouble hearing me, let me know, and I can keep moving. So, Bryana stole my thunder a little bit, so I'm going to skip through this first little part. But as she said, we're here in North Austin, Texas, and we have a 90-bed facility where we serve adolescents and up. And there's just a breakdown of our beds and our units. So there's 3 different units that we have, where we serve geriatric, especially population in our PICU. Experiencing some level of psychosis. So just prepare for that. And then also we have our partial hospitalization and intensive outpatient programs, which we already talked about. You'll get a copy of this PowerPoint, so you'll be able to see the admissions process that we have here. But we try to keep it very quick for anybody that comes through, specifically for law enforcement. So I will have that as part of the slide. And then here we have just kind of all of our important key players at the hospital. Obviously, the most important are the bottom 2. And we'll get started. So I'll start with, initially the presentation that I put together was Introduction to Psychotic Disorders. And I do this presentation fairly regularly for Austin Police Department and local PDs we have around here. But I decided to scale it down a little bit to specifically psychosis. One, because there's a lot of psychotic disorders in the DSM-5, and the ones that I'm not going to talk about aren't as commonly diagnosed, and they're not commonly seen in most settings. So there's some that I left out purposely. So if you have any questions about any of those, I know a lot of them, but if I'm not on here, then some of them I'll be guessing about. So just FYI. So objectives today, just going to provide a basic introduction on psychotic disorders, their causes, and most common treatments. Going to help you all differentiate between psychotic disorders and mood disorders with psychotic features. And then we're going to discuss some legal and ethical concerns regarding the treatment of psychosis. So I want to start a little bit with a little case study, and I want you guys to watch this video. The actual video that I'm going to play is 10 minutes, but I'm going to play you guys about a little bit under 2 minutes of it. But many of us here in Texas remember the case of Andrea Gates. So I'm going to play just a little bit of it for you all, so you all can get a brief introduction to Andrea Gates. For those of you all that have a pen and paper, I want you to take some notes about observations or things that you pick up from the video, because we're going to talk about a little bit later. So.
It was the unthinkable.
Okay, so again, we'll come back to that video in just a little bit. So I want to start off by giving a very basic definition of psychosis. So it describes conditions that affect the mind where there's been some loss of contact with reality. So during these episodes, a person's thoughts or perceptions are disturbed, and they have difficulty with understanding or differentiating with what's real and what's not. And there's, just like with any disorder or any medical condition, everyone kind of experiences differently. So there's no one way or no one thing that everybody experiences with psychosis. It all kind of happens very differently for each person. The one thing that most people say about psychosis is that a psychotic episode can be frightening and confusing. And as we talk through a little bit more, if you think about you being the only person in the room who believes something and having to defend that, and other people are telling you it's wrong, or if you're experiencing something that is actually frightening, or having someone talk to you in your head or things along those lines, it can certainly be a frightening experience, especially if no one else is able to corroborate what you have going on.
Hey, Brandon, I'm sorry to interrupt, but I've had people say that they're having a hard time hearing you, I guess, because of the distance to the microphone.
Right up in y'all's face. 1 second. Can you all hear better?
Yes, much better.
Okay. So I just gave well, I guess you all can read what I wrote, but I just gave a brief definition of psychosis. And as far as causes, there's not one specific cause of psychosis. Obviously, there's mental illness that can cause someone to have a psychotic episode. So schizophrenia is a psychotic disorder that's characterized by psychosis. And bipolar disorder or chronic severe depression are disorders where you can have psychotic features where they don't last the entire course of your mental illness, which we'll talk about later. Genetics, so there's no one test, or there's nothing out there that we can predict that someone's going to have psychosis or mania or things along those lines. But there's a pretty good correlation between family members having psychosis or mental illness and kids having it, and on down the line. So more so if your mom and grandmother have psychosis, then your slightly increased increased chance that you might likely have a psychotic episode down the road, versus your aunt and your cousin, you may not be as likely to have an episode. Recreational drugs, so it can be triggered by the use of drugs, including cannabis, amphetamines, mushrooms, and other types of hallucinogens. Some other causes that aren't as common but are important to note are medical conditions. So stroke, brain tumor, epilepsy, and Lyme disease are all diseases or conditions that you change over the course of time. Things might get worse. You might have issues along the lines where you start to have deterioration, versus something like HIV and AIDS. So this disorder, if someone has like an untreated infection, they might start to show signs of psychosis. And as we treat the AIDS or HIV, the idea is that the psychosis will resolve, versus with a stroke, brain tumor, or epilepsy, there might be some more damage to the brain that's going to not allow you to completely come back to your normal level of functioning. Some medications can cause psychosis, so pain medications, cold and flu medications like Orsedin, some people use, or different kind of cough syrups. Sleep deprivation, oxygen deprivation, and fluids deprivation can also be some causes for psychosis. And we'll talk about sleep in a little bit. So I'll do this caveat that I'm a social worker and I'm happy to be a social worker, but I understand that we have to talk a little bit about the science piece. So I'm going to communicate to you all this the best way I know how. But essentially what the research says is there's a dopamine hypothesis which suggests that schizophrenia involves excess dopamine activity. So there's been studies that show that if you look at a PET scan, there's activity in the occipital lobe when someone's experiencing a visual hallucination, or in Wernicke's area when someone's experiencing auditory hallucinations. So essentially what that's saying is when someone is experiencing these hallucinations, there's some activity in their eye area. And same thing with auditory, there's some activity around the ear to indicate that is thought to be hyperactive in schizophrenia and to mediate the positive symptoms of psychosis. And then dysfunction in the mesocortical pathway can cause negative and cognitive symptoms. So this is another dopaminergic pathway that connects the ventral tegmentum to the prefrontal cortex. So I want you all to remember from this area is that it's thought to be involved in cognitive control, motivation, and emotional response. So motivation and emotional response is affected with negative symptoms, which we're going to go through here in just a second. Symptoms of psychosis. So again, if you look in the DSM, there's a lot of information about psychosis, and I didn't want to put everything up here, but to summarize it and make it easier, these are the kind of three trademark symptoms of psychosis: hallucinations, delusions, and disorganized behavior. Hallucinations are sensory, delusions are false beliefs, and then disorganized behavior where they go through some of those. And every disorder that's a psychotic disorder has some level of one of these. And we'll talk through some of that shortly. So again, hallucinations, a false perception of objects or events involving your senses. So there's several types of hallucinations, but these 5 that I have on here are the most common. And those are your 5 senses. So auditory are the most common. So this is typically someone that may be hearing something that other people don't hear. You can hear something negative, positive, or things commanding you to do certain things. So you may hear someone say that the voices told me to kill myself. The voices told me to turn my wheel and drive off the highway, things along those lines. But there's also some times where somebody may report that it's a more positive experience, meaning they may be having a voice that they're talking to, like a friendly person that's giving them some conversation in their head. But for the most part, it's usually something that's more negative in nature, negative or neutral in nature, I'll say. I want to note that this is different from your running internal commentary or internal dialogue. So all of us have a voice that's going on in our head while we're awake. Every time we're awake, something's going on and we're talking and thinking. So this is different because when we're talking about auditory hallucination, these are things that are not real. Your voice in your head that's talking to you is just your voice in your head that's talking to you. The reason why this is important is sometimes when you're talking to kids or doing assessment with people who may not have that understanding, you may ask them, are you hearing things right now? And of course they are, because we all hear stuff while we're silent. It's natural. But again, are you hearing things that aren't real? So it's very quiet here in this room. Are you hearing anything that maybe I don't hear, or anything that's out of the normal? Or what do you hear right now might be a question you can ask them. Visual, I would say, would be the second most common. It involves seeing things that aren't real, like objects, shapes, people, animals, or lights. There's a little bit of argument about whether or not people can see things that are real things, quote unquote, or things that they don't necessarily recognize. So, for example, sometimes, again, with kids, they may say, I see my dead family member, I see a real person somewhere. Some people argue that it's more so someone that you don't recognize, someone that you've never seen before, or objects in your periphery, or lights, smoke, things along those lines. So people are seeing things that other people are not able to see. We have tactile hallucinations. These are, so tactile is touch. So these are things that you feel in your body or movement in your body that's not real. This is kind of more common with some of the substance abuse, substance-induced psychosis. So you may hear people say that they feel something crawling on their skin. My skin is hot to the touch. I feel like I'm burning inside. My internal organs are moving around. Things along those lines. Olfactory is your smell. And so experiencing smells that don't exist or no one else can smell. These last two are a little less common, but with olfactory, someone may say that they have a consistent smell of gas or a consistent smell of rubber burning, but no one else is able to experience or notice that smell. Gustatory is taste. Taste, these are when tastes are often strange or unpleasant. It's really common with people with epilepsy. They have a metallic taste sometimes in their mouth. Same thing with gustatory. Sometimes you may, the example I like to use with gustatory to kind of make sense to some people, even though it's little, maybe doesn't need too much of an explanation, but if you think about lunch meat, when you go to the grocery store and you buy smoked turkey And let's say I buy some smoked turkey and the smoked turkey ends up not being good. And I take it back to the store and say, this is some bad smoked turkey. I get new smoked turkey and I like the way the smoked turkey tastes. Someone with gustatory hallucinations, they're gonna, no matter what kind of smoked turkey you give them, they're gonna have that taste of gasoline in their food or the taste of metal in their food. So they will have some difficulty with just enjoyment of certain things because they're not going to be able to, they're not able to not taste or experience this bad taste in their food. We have also sleep-related hallucinations. So I will say that these aren't as common, but we have hypnopompic hallucinations. They occur as you're waking up from sleep, and hypnagogic hallucinations that are happening as you're falling asleep. These are maybe if you, with hypnopompic, so for example, if you have been up for a very long time and you're trying to get to sleep, but you're having difficulty getting into your sleep cycle, then you may see a shadow in the corner, or you may start seeing orbs of things in your eyes. But typically with these hallucinations, they resolve, once you go to sleep and you wake up and there's no more hallucination there. Same with the hypnagogic, when you're falling asleep. I'm sorry, I put it backwards. So when you're waking up, for example, if you wake with hypnopompic, when you're waking up, you may be a little disoriented, which sometimes we often are when we wake up from a long nap or a night of sleep. And so when we sometimes may see things that are not there, or hear something weird that woke us up, but it ends up being something, a figment of our imagination. So again, these are typically short lasting and no cause for concern. And they are often associated with sleep disorders. So it's typically not something that you're just going to have randomly, but I wanted to make sure that I put that in there because some people do experience it without the sleep disorders, but it's not necessarily a diagnosis of sleep disorder. Delusion. So delusion is probably a little bit more difficult to treat because these are false beliefs or ideas that are not based in reality, but held with strong conviction, even when presented with evidence they are untrue. So again, I'm a social worker, and I always tell people there are certain things that you argue with people about and certain things that you don't. And with someone who has these delusions, these are, while we know they're false beliefs and we know that there's evidence otherwise, we don't want to argue in these situations because, again, it's held with strong conviction and they believe that it's true. Delusions can occur with or without psychotic symptoms like hallucinations, disorganized thinking, or speech. And they can come in many forms, but there's some types of delusions that are more common than others. So DSM-5 identifies 4 main categories of delusions. We have bizarre delusions that are normally odd, strange, or unrealistic in nature. Example, I was abducted by aliens last night, and I'm here, but I'm not really here. Right? Or supernatural power, something like, I know you see me here, but I'm not here. I'm not actually Brandon. I'm someone that resembles Brandon. I'm someone that talks like Brandon, but I'm not Brandon, right? So these are things that are less likely to happen, bizarre delusions. Non-bizarre delusions are delusions that are more realistic in nature, but still unlikely to occur. So that can be like beliefs of being followed, poisoned, or stalked. So one I use whenever I do this one is that my name's Brandon Willis, and I just got off the phone with the former President Barack Obama, and he told me about some very interesting things that went on in the White House that no one else knows about. Right? So if you look at that one, I'm real, Barack Obama's real, he was a former president, there's a White House, right? But how likely is it that I met Barack Obama, talked to him on the phone, or had coffee with him, right? So that would be more considered a non-bizarre delusion. We have mood congruent delusions that occur when someone's experiencing strong emotions, so maybe some paranoia when you get anxious, or mood neutral, and these usually occur not when there's strong emotions present, so they can kind of happen anywhere. They typically seem to come out of nowhere. So I broke out there's several different types of delusions, but the ones that we probably work with the most, grandiose delusions. This person has an overinflated sense of worth, power, knowledge, or identity. Example, I'm the reason why this hospital is open. You guys will fail without me. Okay. I'm the reason why, whatever. Right. So there's a number of different things that we consider grandiose, but essentially this is someone who has a really high opinion of themselves, and it is not 100% true, or it's not necessarily true. Persecutory delusions. This person believes they're being mistreated, or someone is spying on them or planning to harm them. So again, using the neighbor example, if I'm scared of my neighbor and I think my neighbor's looking through my window, and my neighbor has a plot to come over here while I'm asleep at night, so that's why I sit in my living room. And that's why I keep my doors locked. That's why I add an additional lock into my door so that I can make sure my neighbor doesn't come in. Okay. That's going along the lines of persecutory delusion. Jealous delusion. Example would be someone thinking their spouse or partner is being unfaithful, and there's no evidence otherwise. Okay. So some people may experience this, right? And it might not be considered clinically a delusion, right? So sometimes we may have suspicions about someone being unfaithful, right? But again, with this one, it's more so I feel like it's a fixed belief that my spouse or partner is being unfaithful. So I'm stuck on this, and I'm doing things to prove or to identify that my partner is cheating on me, and they're not actually, right? There's nothing that's really there. Somatics, person believes they have a physical defect or medical problem. So self-explanatory, but if someone says that I am convinced that I have cancer for whatever reason, right? And we may have them go take a test, we may rule out cancer. There may not be any physical symptoms going on that might indicate they have cancer, but this person is convinced that they have cancer. Erotomanic, so this person believes someone is in love with them and might try to contact that person. So we kind of see this with celebrities often. I think a good example, and probably not the most appropriate example, but if you're all familiar with Eminem, the rapper, he had a song back in the day called Stan. And it is a good example of erotomanic delusion. So that person was a fan of Eminem's, who wrote a letter to him. Essentially, the guy fell in love with Eminem, and he was going from show to show to show to see him, and then blah, blah, blah. So it's a really good example of erotomanic if you guys can stand a little bit of cussing, but it's there's some psychology in that song, and I want to make sure you guys learn it and understand it. So I broke out religious delusions for a couple of reasons. One, because of the Andrea Gates case, and also because it's kind of controversial in nature. So I respect all beliefs, but let's think for a second. So there's some research out that essentially states that religion in itself is a mental illness, right? So we talk about like Christianity. We believe in someone who was here, who died, came back, and is still with us right now, right? And so let's say that we replace that with another person, right? A regular person on the street. If we were to tell that story to someone, then we might think that person has some kind of psychotic disorder going on, right? So the challenge with religious delusions is that based on your faith and based on your beliefs, everything in your book or however you used to worship is true. So for example, everything in the Bible will assume is true. So many patients, when they're starting to have these delusions, they will start to quote information from the Bible, and they will become increasingly more religious. For example, they may be able to quote the story of walking on water, and because he walked on water, I can walk on water as well, right? Or any other story that's kind of fable written. They may think that they're able to do those similar things, and they're not. Okay? Many patients with psychotic disorders use faith as an important coping mechanism, and so some people may become hyper-religious, where either they're quoting scriptures excessively, or they become more involved in the Bible or whatever book, and they start to memorize and start to obsess kind of over those different things that come along with religion. Some studies found that religious beliefs as a whole contribute to better outcomes, but we've also noticed that it can be associated with a more serious course of illness and poorer outcomes. So essentially what that means is as the disease gets worse, some people will have more increased religious delusions. And again, because these are fact and things that we know to be true based on our faith, it sometimes becomes a little bit more dangerous because it ends up being one thing that they're really stuck on. And patients with religious delusions usually have more severe psychotic symptoms, a longer history of illness, and poorer functioning. So we heard at the very beginning about Andrea Yates, and if you keep watching that video, it does go into some information about her wanting to go get back into the church, which was a big coping mechanism for her prior to the crime she committed. So she reported that there were some religious delusions that she had, and this can be, and so again, so they were persecutory in nature. So what she was saying was that her kids were Satan was inside of her, and her kids were doomed to suffer the fires of hell, right? And so that's worrying. It's religiously based, right? And so because she had that fixed delusion, that fixed information in her mind, she proceeded forward with the crime that she committed. And so again, with all delusions, there's concern, but religious delusions are challenging because, especially clinically, we never want to necessarily challenge the religious beliefs, but you also have to be aware of the fact that it's something that's a coping mechanism, but also can be an indicator of someone being sicker than they have been. Disorganized behavior is another symptom of psychosis, and it can manifest in a variety of ways. So it can be some odd behavior. So one of the more common ones is responding to internal stimuli, or internally preoccupied, where someone's either verbally responding to someone that they're hearing, they're physically responding to something, so they might be jumping or making weird movements because they feel something inside of their body. Purposeless and ambivalent behavior or movements. So one example, I guess you guys see me in the corner of the screen, but one example, someone might walk around with their arm going like this, right? And that's just what they do. And there's no purpose to it. They can't explain to you why they're doing it. It's just part of their behavior. And disorganized behavior can also include random intermittent agitation for no clear reason. It can also present like childlike silliness or unpredictable agitation. So childlike silliness might be where someone is always they're laughing or speaking in a childlike voice, or not doing things in a manner that we might assume adult would perform. So maybe if they're in the cafeteria, they're not eating with utensils or eating with their hands, or they may struggle with things like hygiene because they feel like they don't know it, essentially. They may be disheveled, dressed in unusual manners, and they show clearly inappropriate sexual behavior or just clearly inappropriate behavior at all. So in this symptom, it's things that are kind of socially inappropriate or things that we don't typically expect. So disorganized behavior, I kind of refer to it as things that we don't expect from someone, versus when I eat, right? People are going to expect to see me eat mashed potatoes with a spoon versus with my hands. So it's things that are outside of the normal. I'm going to go through a couple different examples of disorganized speech. So the dictionary definition is discourse, sentence, clause, phrase and word approximations. But what we're going to do for clinically, we're going to use derailment, incoherence, and neologisms. So derailment, typically it's unclear. Well, it is unclear, confusing connections between larger units such as sentences or clauses. So in derailment, it is usually that the sentence makes sense, but your paragraph doesn't make sense. Okay. So there might be several different sentences that are put together into one thought, but the thought itself doesn't really make sense. So I have an example here that I usually have someone read, and we go through and figure out what this paragraph is saying. But I found a better video that I want to share with you all. It's about a minute long.
The third type of symptom that may be present is disorganization of thought and speech.
So that the thoughts are disconnected, and when a person speaks, there's either a great deal of tangential, circumstantial, rambling kinds of lack of connectedness of one thought to the other.
Like in the daytime, when I go outside in the sun, I used to show my friends they hadn't seen before, like the halo. See, like halo. When I was 19, when I was preaching, I had my trial time. I used to see the light on my shadow on the ground in the daytime. And then now, ever since then, it's like the light coming and pulling down over my body, around my shadow. It's over my body, around my shadow, and I see the light, which is your halo, your aura. And that's why everybody can't see that. But if you see, you got something to do with the drugs too, we say. And now I don't know what's for real. I know what I see, but I don't know if it's for real or not. And so that's why I say people are different. It's like that anointing. I see, like sometimes when I come outside, I can see when I look at the tree, the wind starts blowing. But we know we get oxygen from the plants, and we get them carbon dioxide. And so it's the wind usually blows sometimes, but it don't blow all the time. Like when I'm in the house a long time, it blows real strong.
Okay, so in that example, you probably heard some phrases or sentences that actually make sense, but overall, what he was saying was difficult to follow and difficult to understand. He was exhibiting what we call tangential or circumstantial speech. Tangential meaning going off on a tangent. Circumstantial is more cyclical speech where there's no, you're kind of talking in a circle and there's no end to it or no out. Another type of disorganized speech we call incoherence or word salad. So it's a pattern of speech, again, that's incomprehensible at times. It's relatively rare, but when it occurs, it's very extreme, and milder forms are less common. So the difference between word salad or incoherence and derailment is in incoherence, typically you may be saying phrases, words that make sense, but now your sentence doesn't make sense, okay? So there's probably several different words in a sentence that aren't making a complete thought. And so now that your sentence is disorganized, your paragraphs are now disorganized, the whole thought is disorganized, and no one's really following. So here, on last video, we have from Boston Legal. So he's going to give you a good example of word salad.
Percent of the groundwater in the United States, 40% is contaminated by industrial, agricultural, household pollution. Over the last 5 years, hundreds of thousands of blood tests given to Massachusetts children have shown elevated levels of lead in their blood. And yet, what is our biggest fear? The dirty bomb, not the dirty water.
Objection, Your Honor. Mr. Shore is introducing evidence in his closing that was never presented at trial.
Nonsense, Your Honor. I refer you to plaintiff's exhibit number Apple. Beg your pardon? Apple trash can speak from God.
Huh? Mr. Shore.
You're 60, but classic electrons are free. Objection. I think.
Mr. Shore, you have a notorious history of courtroom theatrics. If your aim is to force a mistrial, you will be disappointed.
Civil plans joined forces over embargo pylon. You aren't sailing past honor for the liking of a room. These questions are birthday basements. To end the blue radish is the upside of luxury, and sparking a good lizard can only make tears fall in hindsight. Puddles do not ask for why not. It is cheese, breath, and win. It is cheese.
Okay, so again, kind of some theatrics on in the actual show, but essentially what he was saying made sense to him, and he was able to communicate in a manner and use body language that indicated that what he was saying made sense. But as you can see, us on this side didn't really understand what he was saying. And again, it's normally very severe when you do see it in real time. Neologisms are completely new words or phrases where you can't understand. This is also pretty rare, but
I have to interrupt. We cannot hear it all now. We are unable to hear. We heard the video, but not you speaking afterwards. Thank you.
All right, what about now?
No, sorry, Brandon, still no sound for some reason.
What about now?
Yeah, I don't know if it's a directional microphone, maybe move a little closer to the microphone.
Can you all hear my voice? Just not loud.
A little bit better.
All right, what about now?
Yeah, yeah, a little bit better. Yeah.
I'll get right up in the camera then. All right, so if you have some difficulty hearing me, I'm getting our IT to come in here and see if they can.
Actually, that's great right there.
Okay. Sorry about that. So basically what I said after the video is that what he was saying made sense to him. His body language indicated that what he was saying made sense, but us on this side didn't understand 100% what he was talking about. It didn't all piece together. So neologisms are completely new words or phrases where we can't really understand where it's derived from. And it's also fairly rare. So example here, I got so angry, I picked up a dish and threw it at the Geshinker. So every word in that sentence makes sense except for Geshinker, meaning none of us know exactly what it is, but we can kind of infer that the Geshinker is the sink, the wall, the floor. So we can kind of make an inference, but for the most part, it's typically something that we don't know where it was derived from. All right, so moving into, I'm going to go over just a few of the disorders. So schizophrenia is probably the more common, or the one that we typically think about when we're talking about psychotic disorders. So it's a serious mental disorder where people interpret reality abnormally. And typically you have to have 6 months with at least 2 of the following symptoms. So symptoms that we've already talked about: delusions, hallucinations, disorganized speech, and some negative symptoms. We're going to go through negative symptoms in a second. Schizophrenia is a chronic disorder requires lifelong treatment. So it's unfortunately one of those disorders that doesn't resolve. Always have to receive some level of treatment. The good news is the whole purpose of having medication is to have the symptoms lessen. So the voices to lessen, or to have any kind of psychotic symptoms to not be as present as they are when you're in an acute episode. A patient who has symptoms of schizophrenia for 6 months or less is diagnosed with what's called schizophreniform disorder. So the best way to describe schizophreniform, aside from the fact that it's 6 months or less, is that it mirrors or looks like schizophrenia. But if your symptoms resolve before that 6 month period, then you would likely meet more criteria for schizophreniform. So if you look at the N form, is where I usually use to help remember, is that it's a form of schizophrenia, but it's not an actual diagnosis of schizophrenia. Again, if you go through the DSM, there's a lot of different psychotic disorders. So, and the ones I'm going to go through are more common. So schizophreniform isn't as common because in the settings that most of us work, we don't see patients long enough to be able to give some of these diagnoses. And again, schizophreniform is not one that's widely used. Typically, in a setting like a hospital, we'll go ahead and just do a diagnosis of schizophrenia based on family history and our assessment. So I've already gone over the top 4 of the symptoms of schizophrenia, but I'm going to go through these negative symptoms. So we have what's called positive and negative symptoms of schizophrenia. So positive, easiest way I try to refer to it, are things that a patient with schizophrenia has that someone without schizophrenia doesn't. So things that are added to them. So hallucinations, illusions, disorganized behavior, et cetera. Negative symptoms are things that a patient with schizophrenia does not have, that someone with schizophrenia does. So poverty of speech, flat affect, poor attention, abolition. So it's loss of motivation, which we saw earlier when we talked about the brain stuff. Lack of pleasure, lack of social interest. In the interest of time, I do have a video that kind of gives an example of poverty of speech, but essentially what it's talking about is if you're talking to someone and they give very short one-word answers, or there's long pauses between their words, or they answer really only what is asked. So, what's your name? Brandon. How are you doing today? Good. Where do you work? Cross Creek. Right. So, not really engaging in conversation. And so, it's really kind of more, it's an impairment socially, right? So, we might expect someone to say, I work at Cross Creek, I'm the director of clinical services, where do you work? Right, to continue to help the conversation to move forward. So positive symptoms, a patient has to have at least 2 of them to get the diagnosis of schizophrenia for 6 months. And there has to be some negative symptoms present also to meet the criteria for that diagnosis. We have substance-induced psychosis, and so it really kind of mirrors any other psychotic disorder, but this is brought on by the use of some type of substance. So hallucinogens, marijuana, opioids may cause someone to have symptoms of psychosis when they take that drug. In cases with substance-induced psychosis, when a patient either comes down from the drug that they've taken, or they've taken some medication to get rid of whatever psychotic symptoms they're having, then typically it's going to go away. But there are some cases where the psychosis is longer term and lasts for months or years, or causes some kind of longer term social impairment. So some of the negative symptoms we talk about might hang around when someone is using a drug and has the psychotic episode attached to it. So treatment for substance-induced psychosis is a calm environment. Depending on what the substance are coming off of, using a benzodiazepine or antipsychotic, which we'll talk about. The important one I want to, so for substances with actions that do not involve dopamine, observation may be all that's needed, or an anti-anxiety medication may help. So whenever there's not that, so that there's other neurotransmitters that are affected by substance use. And essentially what it's saying is if it doesn't involve dopamine, you may just need to be looked at. If it does involve dopamine, it may have some other type of effect. So if someone is coming off like amphetamine, they might be having some different types of effects versus if they're coming off of another drug that doesn't involve dopamine. All right, so I'm going to go through these real quick also. So we have what's called specifiers in the DSM. So diagnoses that have psychotic features, and these are also probably more common than what you'll see than some of the other diagnoses that are in the DSM. So we have major depressive disorder with psychotic features. So essentially a patient has to have 5 of the symptoms that I have listed here within a 2-week period that are changed from previous functioning. So they meet criteria for major depressive disorder, but they will also have hallucinations or delusions or disorganized behavior in their depressed episode. So essentially what happens here is a patient might be so depressed that they slip into psychosis. That's how I try to describe it easiest. Again, when someone takes medication, ideally the hallucinations and delusions will resolve once you get back to your baseline. With bipolar disorder with psychotic features, this is also fairly common. So we know with bipolar, I'll give you a brief class. We know with bipolar, there's 2 poles. We have mania and depression. So with bipolar 1, we have where the patient goes all the way up to mania, all the way down to depression, experiences all the symptoms in between. Bipolar 2 is hypomania down to depression. So bipolar 1 is more severe because mania is more severe. And a patient will get a diagnosis of bipolar 1 disorder, even if they've only had 1 manic episode in their entire life. And with the psychotic features, when someone comes into a hospital, typically with bipolar disorder, they're going to come in their mania or the depression. So with bipolar disorder, someone may be so manic that they slip into psychosis, or so psychotic they slip into psychosis. But at their baseline, they're not hearing or seeing things that aren't there, having the psychotic symptoms. With bipolar 2 disorder, a patient can have some psychotic symptoms, but it's typically going to be in a depressed episode. They're not going to have the depression or the psychosis in the hypomania. Hypomania is more of a more normal level of functioning. Most of us try to reach hypomania by drinking coffee, energy drinks, things that give us a little bit more energy. So hypomania is a little bit more socially acceptable versus the depressed episode in bipolar, where it's usually the most severe in that piece. So again, with psychotic features, the bipolar disorder will have those psychotic features at the very top of their episode or the very bottom of the depressed episode. Now, going back a little bit, so schizoaffective disorder is another psychotic disorder that I skipped over because I wanted to compare to bipolar disorder with psychotic features. So as we talked about bipolar disorder, it's a mood disorder. Now in the DSM, the chapter is called bipolar disorders. But you can have psychotic symptoms, but they're always attached to your mania or depression. So like I said, when you're manic, you have delusions, you're depressed, you have the delusions. Schizoaffective disorder is a mood disorder combined with separate psychotic symptoms that are not attached to mania and depression. So essentially what that means is if I have bipolar disorder and I take my mood stabilizer and my antipsychotic, then I'm good, I have no voices. Schizoaffective disorder, I may take the same medication and I may have less voices. I may not be as affected by the voices that are going on, but at my baseline, on a norm, I'm going to always have those voices there. Most people, when you ask them for a diagnosis and to give you a diagnosis of bipolar schizophrenic, they're typically referring to schizoaffective disorder. So it really mirrors bipolar disorder, but schizoaffective is not solely the mood disorder, and the symptoms don't 100% go away. They'll always be there. And so I skipped over part, I'm sorry. So schizo obviously comes from like schizophrenia, affective is affect like your mood. So if you put two together, it makes schizoaffective. So it's a combination of schizophrenia, a combination of bipolar. So I don't know how well you all can see this, but this kind of just explains a little bit what I just talked about. So you can see my mouse. So for example, here we have major depressive disorder. So let's say I'm at my baseline. We have nothing going on here. I slip into some depressive symptoms where I'm not able to get up and get out of bed, but I can go to work and, well, I can get up out of bed, but I can go to work and not enjoy it. Versus major depression, where I'm having difficulty getting up, difficulty taking care of my hygiene, not eating, and I might slip into psychosis, which is what this one is here. And then I take my antidepressant, might get back up here, and I go back to my baseline, no voices follow me, right? Bipolar 2, you see there's no voices typically. Bipolar 1 is up here in my mania, then I may start hearing voices, take my medication, I get down to my baseline. Let's say I slip into my depressed episode, I might start hearing voices here. Once I take the medication, I come back to my baseline. So these lines here, so mania at the very top, hypomania, again, mania is more severe than hypomania, our baseline. Depressive symptoms, again, are where I'm still able to participate in life and have a fairly normal level of functioning, but major depression is usually where I'm severely impaired by my depression. And so I can go through this a little bit more, but I'll want to get through the rest of it, but it'll be a part of the PowerPoint. But it's a good little visual to teach people how mood disorders look and how they compare to schizoaffective, which is this one here, where you see voices at all of them. All right, so treatments. So it involves a combination of psychotherapy and medication. There are several different types of therapy that we've seen that are helpful in treating psychosis. Most people, when they come to the hospital, it's not likely that you have someone come into the hospital with psychosis and not get prescribed antipsychotic. So the easiest way to kind of describe antipsychotics that are important for clinicians to know, or someone who's not a doctor or pharmacist, we have what's called first generation antipsychotics, or known as typical antipsychotics. They block the dopamine type 2 receptor, and we use the first generation to reduce the positive symptoms of psychosis, so hallucinations, illusions, disorganized behavior. They're usually not as effective in treating negative symptoms. The first generation antipsychotics usually reason why a lot of people will get off of them or struggle with them is they may cause EPS, extrapyramidal symptoms. I'm sorry, and that may be where essentially it's like allergic reaction. So you may have some kind of involuntary muscle movement in your body, and you have to take some medication to come out of that, out of those symptoms. So that's more common in the first generation antipsychotics. Haldol is one of the most preferred first generation antipsychotics, and that's the medication that we talked about Andrea Gates. That was medication that she was on and came off before she committed her crime. The second generation, also known as atypical, they generally have a lower risk of EPS or tardive dyskinesia, which is if you ever see people involuntarily move their mouth, that's an example of tardive dyskinesia. They have a higher risk of metabolic side effects. So people who are on second generation antipsychotics will typically stop them because of the weight gain. So a lot of people on these medications, they don't want to gain weight, but their metabolism increases, so they get hungrier and then subsequently gain weight. Clozaril was the first second generation antipsychotic, but is now used for treatment resistant schizophrenia. So once someone has gone through or has gone through a number of antipsychotics, the doctor may choose to use Clozaril. Clozaril is a little more risky, and you have to have a certain certification, just because of the fact you have to get some blood work drawn, and again, I'm not a doctor, but it's a little bit more risky as a medication to use. So it's usually used as a last effort when we're treating schizophrenia that doesn't respond to other medications. So there's a list of first generation and second generation antipsychotics. So most common ones: Haldol, Thorazine, Prolixin. Second generation, there's a number of them. Ones you probably hear the most often are the bottom three: Seroquel, Risperdal, and Invega. But of course, we also use the top three. In therapy, there's a number in the research. There are some different therapies that you can use to help someone who has psychosis. There is what's called cognitive behavioral therapy for psychosis, or more commonly referred to as CBT for psychosis. And it's essentially psychosis that, or therapy that is focused on someone's thoughts and feelings as it relates to their psychosis. So I want to make sure it's clear that you don't go to therapy to get rid of your psychotic symptoms. The therapy is more so there to evaluate and provide you with some encouragement, in a sense, or to make sense of the disorder and make sense of the voices and make sense of the illusions that you have going on. So we use CBT to help with managing disorder versus curing it. Also, clients are given time to talk about their experiences and strategies that they developed in therapy. So the question I pose here is, when should you do psychotherapy? So this is branded, it's not necessarily research, but if someone's actively psychotic, it's not the best time for you to do intensive therapy with them. I'm sorry. EMDR, for example, is not something you want to do with someone who is actively psychotic or actively manic either. So psychotherapy should be done once the patient has some of the symptoms of psychosis resolved, or they're in a space where there's not as much impairment in the moment. And we can go through reasons why, but essentially, if you're not grounded in reality, then the therapy we're going to be doing is not going to be effective. It's not going to last. Because schizophrenia is a chronic disorder, case management in the community is helpful, family support, and again, psychotherapy, medication, education, and employment. Support, education, and employment are all important for patients with schizophrenia. Again, there's that piece with motivation and having that lack of motivation. And so having a good support system around someone who has those diagnoses of schizophrenia, schizoaffective, schizophreniform, any of those diagnoses, you want to provide as much support as possible. So I think I moved it down. So, sorry. There's we'll talk about it. Let's skip through this for a second. So how do you talk to someone with psychosis? So in summary, so I present this again to the police department. So I try to tell them different ways to communicate with someone who's actively in a psychotic episode or a manic episode. But essentially, it's kind of the basics that we learn as a therapist, right? So if someone's getting elevated or escalates, we don't escalate with them. We stay where we are and we have that conversation with them down here where our voices are. We don't yell or argue with them. There's no, that's not the point where you should be arguing. Empathy is also really important because again, this is a fearful experience for someone. Even if it's something that they've been experiencing for a very long time and it's chronic, it can still be something that's very, very scary to experience. And understanding that that's what's going on is important versus arguing back and forth with them. Also, again, like I said before, I'm a social worker, so I tell people that you don't argue about certain things with certain people. One thing you don't do is challenge someone's beliefs or experiences when they're talking about their delusion. So again, it's real to them. It's their belief, and so essentially we need to stick with their feelings regarding the delusion. You don't necessarily want to go down. So what time did the aliens come? What they look like? That type of stuff. But it sounds like you're really having a hard time with these thoughts you're having. Tell me more about it, right? Tell me more about how you're feeling about these thoughts you're having. And so instead of going down that road of talking about the specifics of the psychosis, we wanted to stick with the feeling. So hospitalization, if you look at a Texas Administrative Code, the reason why we would admit someone to the hospital is if they're a danger to themselves, danger to others, or deterioration of functioning. The Administrative Code is pretty clear about why a person should come to the hospital if they're a danger to themselves, others, or have that deterioration of functioning. So it's very clear of why they should come, what should be going on when they come to the hospital. What's not always very clear is this next bullet, which is criteria for admission versus criteria for continued stay. So what we often hear from families is, last time she was in this hospital 7 days and she didn't get any better. And then we took her to another hospital for 10 days and then she didn't get any better. So we take her to hospital, and we're not seeing any changes in her symptoms. So again, we admit for if they're actively dangerous to themselves, danger to others, or deteriorating. But for continued stay, there has to be limited or no response to interventions, ongoing symptoms, or no resolution of the admission criteria. But also, if someone's not having that medical stuff going on, then it's difficult for a hospital to justify keeping that person in the hospital. So if they're medically clear, if we notice that there's changes in their behavior, changes in what's going on when they came in the hospital, then we are challenged with being able to keep people in the hospital. And nowadays, there's what we call insurance companies who don't allow us to use certain things to say why we want a patient to stay in the hospital. So previously, we might have been able to say that person is still psychotic and they're not with it enough to be able to give me a clear discharge plan. Nowadays, it's not always as easy to use it, and it really kind of depends on who you're talking to. So parents struggle with this. Sometimes patients struggle with it, but the criteria to stay is becoming more and more challenging, which again, with the diagnosis of schizophrenia, sometimes you may need a longer time to treat that person, but you're not always awarded that time just based on one, the administrative code, and also the payer who is giving you pressure to get that person out of the hospital because they don't want to spend more money than they have to. Prognosis. So is psychosis curable? In short, no, but it's 100% treatable. So I gave just some examples that some people may have one episode and completely recover. You may have several and completely recover. You may have some and never recover, right? Someone may always have psychosis. But the important thing is that you can have psychotic features, a psychotic disorder, and still live a productive life. So people can still work full time and take care of families. It doesn't mean that that goes out the window. I want to touch a bit on medication compliance also. So they have what's called rebound psychosis. So this is really common, especially with someone who has schizophrenia. People who have schizophrenia or bipolar typically don't believe that they have anything wrong with them, right? And if you think about mania, if I went more into mania sounds like a really fun experience, right? You're spending money, staying up late, doing all this stuff. So it can be really fun to people. But with psychosis, when you come off your medication quickly and you don't go under a doctor's order, you can have what's called rebound psychosis, where the psychosis comes back worse or more severe. And each time that you come off the medication and get back on, the likelihood of you reaching your baseline, your previous baseline, decreases. So if you see people that are often on their medication for several times and they have what's called anosognosia, which is them not believing that they're ill, then you will see people start to deteriorate and not be able to get back to that normal level of functioning. And so that's just why medication compliance is important to following your doctor's order, because the doctor is going to be able to help with resolving some of that. But it's really challenging sometimes with people who have schizophrenia because they don't always believe that they have that disorder. So I want to go back real quick to the Andrew Yates story. So we talked about Andrew Yates and what she was diagnosed with, and we talked about some of the symptoms that she had. So my hope is that you all were able to identify what symptoms of psychosis she was exhibiting and what things were going on with her that met criteria for psychosis or for her disorder. So the video says she was diagnosed with postpartum depression and postpartum psychosis. One thing I want to touch on that was kind of more on the legal side that was interesting about this case was it really put the McNaughton rule and the irresistible impulse test to test. So the McNaughton rule essentially was back in the 1800s, this man, Dan McNaughton, he loaded his gun, he put some gunpowder in, and he went and shot someone who he thought was a prime minister, but he actually shot the prime minister's secretary. And he said that at the time he wasn't of sound mind, and he thought members of the Conservative Party were persecuting him. And so the doctors who testified and evaluated him believed that his delusions were so strong and out of his control that at the time of the crime, he was not able to differentiate between what was right and what was wrong. And there was arguments with, in this case, because at the time, he may not understand what was right or wrong, but he understands what's right or wrong right now. And so this is what kind of came to play in Andrea Yates' case is if she's with it right now, was she with it at the time of the crime? And did she really understand the difference between right and wrong at the time of the murder? Irresistible impulse test. Essentially, this one was a mom and a daughter who killed the mom's husband, and this one, the defendants said they were unable to control their impulses due to their disorder, they were unable to control their impulses due to the mental disorder. So in that case, Parsons versus State, the defendant was able to tell between right and wrong, but lost the power to choose between right and wrong. So they essentially kind of blacked out what they argued, and they weren't able to identify what was right or wrong at the time of the murder. So these two really became highlighted during Andrea Yates' case because it's not clear, right? And only Andrea Yates really knows what her intentions were and what she really knew at that time. But both of these are pretty interesting cases if you just look on YouTube, or you can even find some of the transcripts for it. But what came to light with the Andrea Yates case was just this issue of psychosis and this issue of treatment, and how she was in and out of the hospital several times. And she was on medication and was taken off medication, and then she deteriorated quickly enough to where she was able to go through with the murder of her kids. And so it really highlighted some gaps that we have in mental health, some gaps we have in mental health in Texas specifically, where we don't always have the most resources to provide to families or the patient when they leave out of the hospital. So it was again a very big case out here in the state of Texas, something that still always comes up whenever we talk about or do any kind of education about psychosis. So that's it from me. So I appreciate you all's attention. I guess we can move to if there's any question.
Awesome. Thank you, Brandon. And here's his information on the screen if y'all want to reach out with questions. Good information. We had a lot of people talking about how this information was helpful to them, and we appreciate you doing the presentation today. You will get an email tomorrow with a link to the evaluation on our website. You could easily print off the certificate. But if you joined by phone, or if you aren't able to pull that up on your computer from all the security that they have now, just email us and we'll be glad to send that to you by email. So thank you for joining us today. I hope you could join us next month on the Starlight webinar series. And that concludes our webinar for today. Have a great weekend.
Thank you,
Thank you, everybody.